Good afternoon, everyone. Welcome to today's webinar. We are going to give it just a couple more minutes as people start to filter in. So we'll be starting shortly. Thanks. Alrighty, so it looks like there's a good amount that have joined. I will go ahead and get us started, but I know there's some more people that will continue to hop on. But thank you again for joining today, guys. Today we are having a webinar via Biome about speaking a common language. So using data to foster alignment between physicians and administrators. So just a few talking points for this webinar that we'll go into. We'll look at the value of harmonizing clinical, operational, and financial data to serve as a single source of truth for effective decision making. We'll also look at how to interpret clinical and financial data together to prioritize areas of need within the CV service line and remove implicit bias. And last but not least, we'll look to advocate to the C-suite for continued investment and resources to support CV service line growth and program optimization. Today, I want to thank our speakers. First, we have Dr. Bradley Hubbard. He is a clinical assistant professor at Michigan Medicine and a veteran in the cardiovascular care space with more than 30 years of experience in both private practice and academic medicine. He has led efforts in practice administration, cardiovascular service line quality, and system level strategy at Trinity Health. He brings a wealth of experience in bridging clinical care and operational leadership. So thank you, Dr. Hubbard. That goes into our next presenter speaker, that is Hillary Nierenberg. She is Senior Vice President of the Heart and Vascular Service Line at RWJ Barnabas Health. Hillary is responsible for system-wide cardiovascular strategic planning, growth, and quality initiatives. She also has over 20 years of experience in leadership in large complex healthcare systems, is known for building strong multidisciplinary teams focused on patient-centered care. With that, I'm going to cover a few housekeeping items before I pass it over to our speakers. So those of you joining today, just a couple of ways to interact with our speakers. So one, you will see the Q&A chat function on your bottom screen. Please go ahead and enter any questions that you guys see fit during the presentation. We will save about 15 to 20 minutes at the end of this to go over any Q&A that you guys have for our speakers. And then last but not least, we also have a chat function. So if you guys are having any issues in terms of technical difficulties, please let us know. We have a team in the background working to fix those. You can also access the slides for today's presentation in that chat function. With that, I'm going to go ahead and turn it over to Dr. Hubbard and Hillary, and we can go ahead and get started with this webinar. Thanks for joining.
Just as far as disclosures, I have recently been asked to be on the advisory board for Biome Analytics, but I have no financial commercial conflicts of interest to disclose related to the presentation. I'm not paid by Biome. I'm just in an advisory position.
And I've got no financial or commercial conflicts of interest related to this presentation. So let's get started. So let's talk about why this topic really matters. We know that strong collaboration between administrators and clinicians is a hallmark of effective cardiovascular service line. But good intentions aren't really enough. Alignment doesn't just happen. We need structure, tools, transparency, and data.
So with this session, we'll explore how using data as a shared language can help overcome some of the common barriers, guide decision-making, and improve how we advocate for resources and change. We'll also share some examples of how we've seen this work in practice. When alignment is working, the impact is clear. Decisions get made faster, goals are clearer, and outcomes improve. You see leadership teams that are truly unified in both their priorities and their accountability.
But that kind of alignment only happens when people are working from the same foundation. That includes access to the same performance data, agreement on what success looks like, and the ability to act on the information together. Next slide, please. Of course, alignment is often easier said than done. We see several consistent challenges that prevent us from taking hold. These include siloed priorities, limited visibility into performance, and data that is either unavailable or disconnected across the system. And you can see from this slide kind of highlights some of the classic barriers to us really coming together on this.
And I think when clinicians and administrators are not looking at the same data, it's very hard to agree on where to focus. You end up with mistrust or stalled initiatives simply because there's no shared understanding of the current state of the opportunity. And I think the issue about aligned incentives that was mentioned is very important. I mean, I think that physicians and administrators are sometimes not aligned on what their actual incentives are in their job. Physicians may be looking at quality, administration is looking at reducing costs. And I think in the end, you have to make sure that you have a common focus and a common alignment to get things done. And we can talk more about that.
So next slide.
This is where the data becomes so powerful. When clinical, operational, and financial information are integrated and accessible, it becomes a single focus of truth. That shared foundation allows everyone to focus on action instead of interpretation.
And it also reduces subjectivity in decision making. When you can point to objective performance trends and compare against peers or internal benchmarks, the conversation shifts. People stop debating the facts and start working on the solution. So it becomes a single source of truth for decisions when data is clear.
You know, Harry, and I think the one thing that I've learned over the years is accurate data because I've been in multiple meetings and situations where you get data coming down, whether it's from Epic, from the system level, and the data has to be verified. Now, I mean, I think our gold standard has been registry data. Registry data is great, but the problem is it's 6 to 9 months out. And you can't manipulate that data. And obviously, there's no financial data. So I think the challenge for us has always been getting good, accurate data. It was interesting when we went into Epic in 2020. We really thought Epic would be the answer to everything. And we'd been told that don't get your hopes too high. And I think we found that Epic, while it's a fantastic electronic medical record, and I've been involved with it ever since 2020, it doesn't always provide all the data that you need. Number two is, I think, the benchmarking. The benchmarking you get from NCDR is fantastic. But for a lot of what you do, you want to know what other practices are doing. MedAxiom has been able to provide that. Biome has been able to provide that. But I think the two things I would take away from this slide is that you're getting accurate data and that you're able to benchmark it, because I think that's where you're going to make a lot of your decisions.
Well, I'm so glad you brought up the accuracy of the data and Epic, which is incredibly powerful. And I know everybody that utilizes the registry data, you need to be able to ensure that the team members that are collecting the data understand the definition. So what goes into the registries is actually representing the patient's acuity, et cetera. So it's so critically important to have processes in place where the data is validated. And if it seems that if it comes out through teams of review, that there's an opportunity to change the data, which really has a tremendous impact on the patient's essential story about what happened and what they are.
Great.
Okay, next slide. One of the best ways to see alignment in action is how quality initiatives are chosen. When decisions are based on both clinical impact and financial return, they are more likely to gain traction across all levels of leadership. It's clinical leadership, hospital leadership, program leadership, across the board.
And I would say this approach helps us avoid the trap of choosing projects based on enthusiasm alone. When the data points to a clear opportunity, it becomes much easier to get agreement and to move quickly. And Hillary, I just want to give an example at our own institution where I think this was helpful. When I was at Trinity, we were part of an employed practice. So we had quality initiatives, and we would sit down with our chief medical officer quarterly and review our quality initiatives. And we had a fairly robust list of quality projects. Pre-COVID, back in 2018, 2019, we did same-day discharge. We had some modest success. We probably were discharging about 50% of our patients after PCI the same day. We saw that as success. We took it off our dashboard. And what we saw is that our same-day discharge dropped down to less than 10%. Very few of our patients were going out. We go into COVID in 2020, and all hospitals really were forced, if you're going to do elective PCI, you had to do same-day discharge because you had no beds. Patients were going to stay in the hospital. So our same-day discharge goes up to over 90%. It then came into around 2022 where our chief medical officer says, we've had success with same-day discharge. Let's take this off our dashboard because, we've got limited resources, quells, and our dashboard was such we couldn't follow too many projects. We looked at the ROI of same-day discharge, and it was 1.2 million that we'd saved. And that wasn't even including opportunity cost of opening up beds. So then we made the decision based on the fact of our historically same-day discharge falling down when we took it off dashboard and an ROI of 1.2 million to say, yeah, maybe in this case we should keep it on the dashboard. And so the point I'm trying to make with this is I think in 2025, you look at the quality impact as well as what your return of investment are when you start looking at these projects, either to maintain it on your dashboard or even picking projects, because most places only have a certain number of FTEs to do quality. In our case, we had one FTE, one quell to do all our work. And as great as she was, she was limited by how many projects she could do. So I started to pick projects wanting to know what's the financial impact as well as the quality impact. And then we chose our projects based on that. And we found that was actually very helpful. And when you start talking about getting alignment with administration and physicians, I think that approach of looking at both ROI, the financial impact, as well as quality impact, really seemed to put us on the same page.
That's a great example. So most systems struggle to access timely and accurate data. Administrators must lead on incentive alignment and data infrastructure. And we need data. We need shared dashboards or platforms to enable transparency. But to have these conversations, people need to have the right data. One of the biggest challenges that we face is the fragmentation, and clinical data may live in one system, finance in another, and operations in another. And you need to have the ability to look at all these data fields together.
And I think the result is a lack of visibility and limited ability to manage performance in real time. Without clean integrated data, even the best ideas are difficult to implement. Investing in data infrastructure is not optional, it is foundational. Even with great data, we need to remember that people act based on what the data means, not just what it shows. It is the story behind the numbers that creates momentum for change.
Absolutely. You can show a line graph of operative time, but unless people understand why behind it and how it connects to patient outcomes or costs, it will not move the needle. Interpretation is just as important as the presentation. When we come to the next slide, we're going to show one example similar to what Dr. Hubbard had shared before. And this is so critically important to be able to have access to this sort of data to really drive home the messaging. So this example is a dashboard from Btwn, which shows operative time for isolated CABG cases and how it correlates to OR costs. When you show this to the clinical and administrative teams together, it immediately prompts the right questions. And you can see, we're looking at on the graph OR direct costs. These are just some of the elements: skin incision to skin close to OR exit, and OR entry to skin incision. So there's various time points that you've got multiple team members that are focusing on these, the whole procedure. But when you have an opportunity to break it down into minutes for each of the buckets, you can take a look at how the OR direct cost actually is reduced when you tighten up the time. And it's having this sort of information that translates from clinical picture to financial, which is so impactful.
And it allows the teams to drill into specific cases, operators, processes, instead of general assumptions. You can look at the variation with clarity. This is how teams move from reactive review to proactive improvement. And Hillary, if I could give two examples, one of the things we worked on over the last few years was our TAVR program. We collected data on TAVR, and it's interesting about TAVR is that a lot of programs losing money with TAVR, or at best break even, and I've seen read where potentially half the programs. At the same time, I've talked with heads of cardiology at various programs, and I'll say, "Do you make money or lose money?" And most people look at me like, "I have no idea." And why is that? Well, that's because when we went from surgical aortic valve replacement to transaortic valve replacement, the valve for surgery costs around $5,000, and for the TAVR valve, it costs around $32,000. In addition, the reimbursement was less for TAVR. So as a result, your margins for TAVR are pretty small. And so I sat on the Trinity service line, and one of our questions there, as we were losing out on the highly reimbursing surgical aortic valve replacement, is our programs making or losing money with TAVR? And we didn't know at Trinity Health Ann Arbor. We started looking at that, and when we first started getting our financial data, we found that we had a very small profit for doing around 200 cases a year. It was maybe about 150 at the time. And so we started for 1 year in 2023, looking at our TAVR program. And what we found was that our length of stay was longer. We were sending patients to our CCU because of access issues in our step down. Our pacemaker rate was a little high, and we had some vascular complications. So we started working on this, addressing this from a quality standpoint. We started looking at what can we do to get these patients out of the hospital? What strategies can we do to reduce pacemaker? And then we started looking at moving the patients directly to step down. And what we found from a financial standpoint was we went from making around $200,000 overall for our TAVR program to $1.4 million. And that was in less than 1 year. Our primary goal was looking at quality, but we found that in the process of improving quality, we could also improve financials. And what we found was that our length of stay went down, our pacemaker rate went down, and our vascular complications. So it was really a win-win. But I want to give one specific example where the financials helped make the decision making. We'd been struggling with getting our TAVR patients to a direct step-down bed, and part of that was a capacity issue. And we'd had multiple meetings over the years with head of anesthesia, our chief medical officer, and nursing administrators. And the problem was we just didn't have capacity to move these patients to a step down or to move them to recovery room. And then our beds were so tight, we couldn't move them from the recovery room to step down. So we had a meeting, and I'll never forget, it was a virtual meeting. I was sitting in the room with the head of our structural heart program. And before I could even say anything, the head of anesthesia just, and he's a good friend of mine, just said, "Look, I don't know why we're meeting again. We can't do this. We just don't have the ability to do it." Chief medical officer echoed the same thing. And I showed 2 slides. I actually pulled this data up from Btwn. The first slide I showed was that 80 to 85% of the country was doing direct to step down for TAVR. So we using our benchmarking data, and we were clear outliers. And no high quality program wants to be an outlier. The second slide I showed, and it's only other slide I showed, was that if we moved our patients from the OR direct to step down, that we would save $500,000. And Hillary, it was complete silence. And we weren't sure, my partner and I weren't sure what was going on. And suddenly the head of anesthesia said, "Okay, we need to do direct to step down." So it changed the whole narrative of where the discussion was going. So that, again, bringing in the financial decisions as well as the quality, because we all wanted to do the right thing. But suddenly, when you're talking about $500,000 for that, you start deciding how you're going to use your resources a little bit differently. So I think that ROI has to be continued, has to be used with quality when you're making some of these decisions.
Absolutely. It helps drive the change that's needed. So next slide, please.
So all this reinforces that data is only as useful as the infrastructure that supports it. We need tools that surface relevant information and teams that can interpret it and respond quickly.
And this also includes structures like dyad leadership, when decisions are made together in real time. The type of collaboration accelerates progress and supports accountability across roles.
And, Hillary, I think what we found at the Trinity level was that even if you have the best data, so I mean, I think as we've talked up till now, accurate data, uh, financial data, ROI data with your quality data is important, but you have to have the structure. Because what we found is even if you have MedAxiom or Biome data, if you don't have the structure to do that, you're not going to accomplish. So you need data, but you also need the structure. Now, what we used at our place, and we had studied other programs, and I know everyone's got their own service line, is we had a cardiovascular service line. And I think the idea of bringing together cardiology, CT surgery, and vascular surgery with administration is essential because you're all bringing different perspectives on. But number two is that some of the solutions we found in cardiology could be used in CT surgery or vascular surgery. But number three is what we really found was also that there was a great deal of respect that came by sitting together. In our particular cardiology group, we also did vascular. And there was always this animosity between cardiology and vascular surgery. Vascular surgery would only get called in when there was a complication. But as we sat down and we started looking at data, building and doing strategic planning together, I think it brought a much different level of respect. Along with the service line, we also had a cardiovascular quality program, which again had vascular surgery, CT surgery, and so cardiology, vascular, and CT surgery all together. And we would meet monthly, and we would look at our specific registries. And again, having all three specialties together with administration, because everyone brought a different perspective there, was very helpful. And again, the sharing of ideas was very good. But it got us to look at our data, our registry data. I talked with a former president of the ACC about a year ago, and I said, almost everyone is in the NCDR. Do we have any idea what percentage of practices actually look at the data? And I was surprised when he said, I think only about 50% of practices actually look at their data on a regular basis. You belong to the NCDR, but you don't look at your data regularly. And so I think that you have to have a structure where you look at it, dyad, all the cardiovascular specialties, but then you also have to have a quality program that's set up to carry that out. And then finally, I think, again, this is where you have aligned incentives and incentive programs that help to force that. Because when people are aligned and you've got, say, a quality incentive program, that helps to drive a lot of the quality work. Our quality incentive program, we didn't have that much money tied up to it. We didn't necessarily advertise to our physicians how much money, but it's a competitive group. And when you say, look, we're getting B on this quality project, people really step up. So I think the quality incentives really were very helpful as we became an employed group.
Those are great points. So another key point is around goal setting. When goals are too broad or disconnected from a reality, they're really hard to rally around. And when they're grounded in data, they become easier to align around and communicate.
I think we also have to tailor how we frame the goals. Physicians often want case level specificity. Administrators may be looking for impact on length of stay or cost. The same improvement effort may need to be presented in two different ways. But I think, Hillary, your point is absolutely clear, is that you have to have clear goals set up from the very beginning. And part of that comes from your strategic planning, right? When we would have our service line meetings, we would have our top 5 strategic goals at the top of the meeting. And so that we all knew what we were working for. And we would review those on a monthly basis. I think communicating effectively out to everyone in the practice. So we would share that in the cardiology, and I know the CT surgeons and vascular surgeons did as well, because that helps to build your culture. And we can talk more about culture coming up, but I mean, culture comes about when a practice or a health system is showing improvement, sharing that data, communicating those goals. So I think goal setting is important as far as driving the engine, so you all know what direction you're going in, but it also helps to build the culture. And I think, again, regular review of the data. So even though the service line would meet monthly, we made sure that was being shared with all the providers throughout the cardiovascular service line. So in the most effective cardiovascular service lines, we see a dyad relationship, not just in name, but in function. That means administrators and physicians are reviewing data together, choosing priorities together, and sharing accountability. As we've talked about, I mean, I think the dyad relationship is just essential. Physicians aren't going to get anywhere without administrators being there. to help drive this through. But the same's true on the other end. You have to have both together at the table, communicating and trusting each other.
When that happens, alignment becomes part of the culture. It's not just dependent on one person or one initiative. It's just how the team works together on initiatives. So when it comes to long-term investment, the C-suite wants a story. We need to connect the data with the results, whether it's in terms of outcomes, growth, or return on investment.
Exactly. When we can show that a quality initiative improves patient care and supports financial improvement, it's much easier to secure the resources needed to sustain the work. So, Hori, I'm just going to go back. I want to go back to our TAVR program one more time because after we had shown this, and again, in our first year, it was less than a year where we had gone up to 1.4 million. Our volumes were going up, our quality outcomes were improving, and we were showing that this was a profitable procedure. So the issue was coming up. The fact is, as we were growing, we needed more resources, and basically what we needed was our own hybrid OR. And what was interesting is because we'd been sharing this along with the administration, and because we were able to show that it was not only growing, but also providing excellent care, but it was also financially viable. It became much better when we started talking about strategic planning and planning for a hybrid OR. Because Hillary, you know better than I mean, you've got so many different asks of you from a strategic planning, and how do you decide what to fund? And to my mind, as a physician leader, I think you had to hit those three things: increasing volume, good quality of care, and financially viable to go to administration to ask from a strategic standpoint. So I think that, again, having all those things there are very helpful when you start talking about strategic planning.
Absolutely. So to close, we want to leave you with a few takeaways. First, alignment is built on shared data and shared goals, and without both, collaboration just breaks down.
I think second, I hopefully I've shared some examples, but integrating the clinical, operational, and financial data into a single system of record is essential. It creates transparency and trust.
And finally, data only matters if it drives action. That means we need teams, tools, and leadership models that can interpret the numbers and move forward together.
Thank you for being with us today. We're happy to answer some questions and continue the conversation.
Dr. Hubbard, Hillary, thank you so much for the insights today in the presentation. Just want to encourage our audience to, again, use that Q&A chat function at the bottom of your screen for any questions that you do have for Dr. Hubbard or Hillary. We do have a few that have already come in, so I'll go ahead and get these started. Let me pull these up. Perfect. Alrighty. So Dr. Hubbard, Hillary, whoever wants to answer this, feel free. But first one is going to be, what are the most common misconceptions or challenges that healthcare professionals face when attempting to break down the barriers between clinical and administrative teams?
Hillary, I can start. I mean, I think
Sure.
the aligned incentives that we talked about. I mean, I saw this on a system and hospital level when I sat on the national service line. Our three goals for the healthcare system was to improve quality, reduce care variation, and reduce costs. And so we were working on that at the service line level. But then when I'd come back to our hospital administrators didn't necessarily either have the bandwidth to do that, or their incentives were slightly different. And so when we started talking about reducing costs, they weren't totally on board with that at first, because that wasn't really one of their aligned incentives. And we took that back to the system level and said, look, our hospital administrators have to be on the same page as the healthcare system. So I think the aligned incentives, also I think, again, as we talked about, between physicians and administration. I think two is trust. And it was interesting when we first started to look at financial data, I think there was a certain amount of distrust because hospital administrators were not used to sharing hospital data with physicians. Okay, so what are you going to do with this data exactly? Are you going to use this to negotiate higher contracts? Well, yeah, potentially we are. If we're showing that we're making money and doing well, we might. But at the same time, there's a lot of benefit from that. But I think, trust is important. I think three, again, is I think setting a proper culture. What is the culture of your hospital? Is there animosity and distrust between the administration? Are you sitting in a dyad relationship and working together? And I think that gets into the history as well. What sort of relationship have you had? When you go to the MedAxiom meetings, you'll hear of all these disasters where employed physicians are trying to get out of their employed contracts because of such a bad relationship with their hospital administration. So we were fortunate. We've always been so fortunate to have such a great relationship and great administrators. But I think culture, trust, history, and incentives are probably the things I would comment on.
Dr. Albert, thanks for taking that question. I totally agree that, when you're managing a system, one of our goals is to reduce variation, which we all know contributes to improved quality. And how do you actually get that to be driven home? And through that, to get there, you utilize data that's benchmarked nationally to look at your opportunities for change. Then how do you communicate it? I mean, as an administrator, yes, it's great to show the ROI, but we need to remember it's about the patient and the quality of care. And we all want to ensure that our mortality rates are low, and what can we all work together to ensure that we are providing the best quality, and we can demonstrate it either through accreditations, reduction in mortality and all the complications that might come from variations in care. So I think I think the trust is also an essential part of this relationship as we drive quality improvement projects.
Absolutely. Have a few more coming in from our audience. So next one's going to be, how do you suggest starting to get the data, operational, financial, clinical, all together? What have you found helpful in this regard? At our health system is all very siloed.
Yeah.
I can share some very recent example of actually looking at having a system-wide approach to cath lab accreditation. So all 12 hospitals were participating in NCDR, 4 cardiac surgery centers, and 8 community hospitals. And when starting to review how everybody is using the data, the NCDR data, there's tremendous variation. Some it's presented in small groups, some had a full cath lab presentation. And when you start taking a look at opportunities to use the data in a standard way across the system, then you start to look at opportunities. Okay, where is everybody? What's below the 50th percentile? How as a system we going to work together to put in action plans that's going to improve the care and utilize the same protocol? So yes, it can be quite daunting if you've got hospital spread and community and academic medical centers. But if you really just take it down to the basics and work with the teams to start using the data in a standard way and have standard conversations with physician leadership and local leadership to drive the change.
Yeah, I think that's a great answer, Hillary. The other thing I would say this, and I want to be clear. I mean, I sit on the Biome advisory, but I used Biome for several years when I was at Trinity, and I think the MedAxiom data. I think NCDR is great, but when you start getting into some of the other registries other than NCDR and STS, it gets more difficult to try to accomplish these things. The AFib registry has not been terribly helpful, and there's not great vascular registries. And so that's where I think you start looking out at other sources. And I know, because we went through this, when you go from it to an administrator and say, look, we want to get additional data. I mean, Hillary, you've got limited resources, right? Most hospitals have small margins, and most hospital administrators are not looking to get more data. If anything, well, we got enough data here. Let's just go with what we have. But the reality is, if you want to start doing some of these things, you've got to look at outside data sources. And let me give an example of the financial. We could never get good financial data through our healthcare system or through our hospital, and we really had to go to a place like Biome to get that. And not only could Biome pull that out, but then they validated it. And so I think when you start looking at that stuff, you've got to start to look at outside, because you can't get that anywhere else. Number two is when we talked about, the dashboard that you had, and we had one quell, using things like MedAxiom or or Biome, you can have a much larger dashboard that allows you to track more data points. Number three is when you get NCDR, your data is what it is, right? But if you want to say, look, I want to break down my TAVR complications, you can do that. And in fact, it was interesting with Biome one time, we were looking at higher rate of heart failure after catheterization. And so, our initial response was, well, we're given too much contrast. Were we hydrating these patients to prevent contrast-induced nephropathy? And so we started to dive into this at Biome. And it was interesting, within a couple hours, they said, this is an abstraction error. And here it gets back to the point we're talking about earlier. Our abstractors misunderstood what they were doing. And they were very fine abstractors. But it was able to help us to pinpoint that this was really more of an abstraction. So we didn't go down a rabbit hole and spend a ton of time. But I think getting back to the point of when you're siloed data and trying to get financial and all of that together, I think that's where you want to start looking at other sources. I mean, if there's another company in Biome, again, one I'm most familiar with, but I think that's where it's helpful to have some of that other data. Some people have great internal data, fantastic, but I think to be able to integrate it, have a large enough dashboard, and be able to break down your data with financial can be a challenge, having that internally.
Just a very brief example on the value of having support as you're trying to drive change and improve quality. We use Biome for all of our cardiac surgery sites. And what I've found most impressive and important is when you're benchmarking, let's say isolated CABG across the board, and in the market that you're at, if you're benchmarked and it doesn't look like your cases are that sick, but you've got a higher mortality, your O to E does not seem to be matching for what it should be when you're benchmarked. And when you start diving into it, it turned out to be a documentation opportunity. And so those cases, by particular cases being identified, to be able to go and educate the team, including the physicians, about all that does need to be documented in order to ensure that it represents the acuity of the patient, has been so incredibly impactful, which ultimately impacts on your financial return.
And here, I think that's a great example. And we found the same thing for TAVR. We were under coding for DRG 266 as opposed to 267. And, as we looked at our data, and Biome was helpful for that as well. I mean, you're absolutely right. It makes a big difference. I mean, I think a lot of places probably undercode DRG 266, which is with the comorbidities. And so I think looking at your data, but also that ability to adjust up your coding and documentation is an equally important part.
Yeah. Thank you both for that answer. I do have a few more coming in. So this question is actually more centered around operational data and not the quality/registry data, but just going into what is a best practice for organization of a data governance committee with physician representatives and administrative leadership to validate and set standards and even gain trust of data being reviewed in these dashboards. And avoid the mistrust comments of data from a variety of physicians in various forums?
Great question.
Yeah.
I think it's very challenging to present data if you're not confident that it's validated. So the data needs to be absolutely pristine as much as it can be. We have set up integrated leadership groups, ILGs, around various specialties. So there's a cath lab ILG, an imaging ILG. So for each specialty, and with that, you have physician leadership from each of the hospitals, as well as administrative leadership. And we bring up quality dashboards. So it's representation from each of the hospitals to review the dashboards, benchmarking, and action plans that are put in place. So you really need to have forums where there's representation from clinical teams, the physician leadership, and administration to ensure that the data is presented in a way that can lead to action plans. I'm not sure if I answered that question completely. So Dr. Hubbard, maybe if you had any additional.
Sure. Matthew, I think that's a great question. And so what we actually found was that as we started to set up our cardiovascular service line and get our data, we had an old hospital policy that said that the chairman of the Department of Internal Medicine could look at any data and had access to any data. And it created a small problem because they started looking at some complications for a procedure and had no understanding of what that data meant. And so suddenly we had a provider who was being kind of put on the hot seat because of some complications, and yet and it revolved around TAVR again. And what they didn't understand was that there's two providers on our TAVRs, a cardiologist on the right side of the table and a CT surgeon on the left side of the table. And when I challenged the head of medicine, I said, so when you were reviewing this data, was it the cardiac surgeon or the cardiologist? And he says, well, I have no idea. And he said, well, I said, well, if you're going to look at the data, you have to understand what's going on there. And I'm not going to say what else I said, but but it was highlighted that you have to have rules. And so I think getting back to that question is when you start sitting down with this, you need to be clear who has access to the data, who can review that data. Now, as I said, in our cardiovascular service line, we sit down monthly, and the first month it might be interventional cardiologists presenting their data. The data goes to the interventional cardiologist, and I would see it too as head of cardiology and head of the cardiovascular quality service line. But it was really the two of us that were seeing that, as well as the associated quell. CT surgery data went through CT surgery. They presented the data to us, but we had specific rules we had agreed upon. And I think that is so important that when you're putting this data up there to help gain trust, you got to have internal rules of who can see that data. And we had struggled with that, the Department of Medicine. I think they still could have access to the data, but they also understood before they're going to comment on it, they had to come to us and understand that. I think the other thing too is that you build trust as you sit there and review the data together, and that doesn't come necessarily right off the bat. So if you're not used to sharing CT surgery data or cardiology data or vascular complications for cardiologists with vascular surgeons, it takes a while to build that up. But I can guarantee you that the more open you are, the more you share, and again, the culture that you build, that trust comes. But you got to have ground rules at the beginning.
Absolutely. Yeah. Couldn't agree more. We do have a few more questions coming in. So the next one is going to be, in your view, how can healthcare professionals effectively balance the need for clinical excellence with the demands of administrative and operational tasks to achieve improved patient care outcomes?
Well, I think the balance is hard. I mean, I think if I understand the question correctly, I mean, it's you need to have physicians that have administrative time and time to be doing all this, and that's a real challenge. When you start giving a physician, a cardiologist in particular, 30% protected time to do this work, and they're getting administrative pay, it can start to create some hard feelings within the practice, because let's face it, generally administrative work for a cardiologist is not as challenging as seeing patients or rounding. I mean, everyone's going to have to take call, but to do that work, you have to decide that that's important, and you have to have someone who's got the administrative time to do it. You can't be doing that after hours. So there's got to get that balance there, and however you decide that protected time. But two is, I think it's important to really foster and have enough people. At times, we had one or two people doing that, but in our case, we had recruited some incredibly smart young people, and we started getting them involved and mentoring them up, and getting young people involved in younger people. That shows how old I am, but younger partners. I think spreading the work out is important as well. So I think when you start talking about that balance, you got to give people the time to do it, and you got to pay them administrative time from the time that they're off from seeing patients and rounding. But I think spreading it out as much as possible also is helpful as well.
Dr. Hubbard, I'd also like to add that it's really important that the administrative structure in the place that you work, that they provide access to people that will help support gathering the data, doing case reviews, putting the presentations together so it is not just on the physician leader to be doing all that, and to invest in, great clinical teams, whether it's a nurse that's interested in quality or PA, APN who's also involved in that specialty, to be able to work together in this dyad structure to be able to support how the message and the quality data needs to be put together. So it's not all on the physician who rarely has enough protected time.
Yeah, great point.
Awesome. We do have one more question. So what emerging trends or innovations do you both see on the horizon that have the potential to really further improve performance and collaboration within clinical teams?
Hmm.
Yeah, I mean, I guess this is going to sound like a commercial for Biome. I mean, I think that the two data sources that we used, as far as uh, innovations or trends, I think the MedAxiom data is phenomenal as far as helping to run our outpatient cardiology practice. MedAxiom had really nice benchmarking, showed what other large cardiology practices were doing, but MedAxiom didn't really wasn't able to provide us with the inpatient data. And so I think the Biome really did a nice job of being able to then provide us with inpatient and a lot of procedural data at a level that MedAxiom. And I don't think I think the two really work very well together. And in the end, if you have both, you can actually say, look, how much money am I bringing in at the service line? And start to break that down so that you know how much the cardiovascular service line is doing. Again, you've got financial quality data that you can look at. You can look at an individual level. We would see differences, within our interventionalists, and so I think having Biome and MedAxiom data for us was extremely helpful and provided a lot of the stuff that we've talked about up to this point.
Yeah, I definitely would agree, but I think we all have to keep our eyes out, utilizing that sort of data as a foundation. But as far as emerging trends, and we're all inundated with opportunities that AI brings to us, utilizing Epic and some of the new platforms that are coming out to provide automated cues to the clinical team surrounding the quality metrics that we're working on. I think it's going to be really impactful, and we should keep our eyes out for how to integrate all these resources that we're using right now, as well as the ones that will be coming.
Hillary, that's a great point about AI, because at the American College of Cardiology meetings in Chicago, so much was about AI. I don't know that AI is quite ready for what we're talking about today from a practice management service line, but it's clearly there in the clinical. But I agree with 100%. I think AI may well have an impact in the future. I don't know, when Matthew, as far as your question now, what AI is there yet. I'm not sure it's quite there yet, but Hillary's absolutely right. I'm sure it'll have an impact in the future.
And maybe I bucketed off AI as the future, but even utilizing, and I'll just give a very quick example of using STS data and Biome and looking at our intubation times with a target to drive that down, utilizing technology within Epic to send alerts to the entire clinical care team. When a patient's leaving the cardiac surgery OR, clock starts 6 hours, 8 hours, 10 hours, to prompt the entire intensive care and APP team to drive, hey, is this patient that's checked, to see whether or not we can extubate the patient. So bringing in the technologies that are available for real-time change, I think is going to be very impactful, and that's current. Maybe AI, you're right, is a little bit further down, but still we need to kind of keep our eyes out for it.
Yeah, great example.
No, I think it's a great point from you both. I think we're just scratching the surface with really what AI can do and how we want to utilize it here in the healthcare system. So thank you both for your talking points, your insights, and the presentation today. I did have no more questions come in. So if there were any closing remarks, Dr. Hubbard or Hillary, I can pass it over to you. But if not, I do want to thank the audience for joining today and your time. And of course, we will have this live on our MedAxiom Academy as well for those that weren't able to attend live. So Any final remarks, Dr. Hubbard or Hillary?
No, I think it was a good discussion. I thank you for inviting me.
Yeah, thanks for the opportunity to share.
Awesome. Thank you
Thank you.
both for your time. Thank you, Byam, for the partnership. And thank you all for joining today. Have a good afternoon.